My name is Dr. Binod Dhakal. I'm from Medical College of Wisconsin in Milwaukee. I'm here to talk a brief update or summary of the study that was presented at ASCO, the CARTITUDE-4 trial. CARTITUDE-4 is a phase 3 randomized study comparing cilta-cel or Cilta-cel versus standard of care treatment in patients with lenalidomide refractory multiple myeloma. Cilta-cel is a dual binding BCMA-directed CAR-T therapy, and it was tested and approved based on the results of CARTITUDE-1 study in which patients had 3 or more prior lines of therapy. At this ASCO meeting, we presented the long-term follow-up of CARTITUDE-1, where patients were shown to have an unprecedented PFS of median PFS about 3 years in a heavily treated setting. In the phase 3 CARTITUDE-4 study, we aim to test Cilta-cel in earlier lines against 2 effective standard of care regimens, namely PVD, or that is pomalidomide, bortezomib, and dexamethasone, or DPD, that is daratumumab, pomalidomide, and dexamethasone, in patients with lenalidomide refractory multiple myeloma after 1 to 3 prior lines of therapy. So the study design is the eligible patients are randomized 1:1 into either standard of care arm with PVD or DPD, and the choice of that regimen is based on physicians and with the prior exposure and prior refractoriness. And then Cilta-cel arm undergoes apheresis, bridging, lymphodepletion, and receiving a Cilta-cel infusion. Now, the important thing to note is that the bridging therapy is the same as standard of care arm, either PVD or DPD based on physician choice. The primary endpoint of the study was progression-free survival, which is defined as time from randomization to either progression or death, whichever occurs first. There are a number of secondary endpoints we aim to evaluate in the study, in particular the response rates, the MRD negativity rates, the overall survival, the patient-reported outcomes, and the safety. In the study, we enrolled 419 patients who were randomized into Cilta-cel, 208 patients, and standard of care 211 patients. In the Cilta-cel arm, 32 patients had disease progression or died before receiving CAR-T, and they are counted as PFS events. And 20 of the 32 patients received Cilta-cel as subsequent line of therapy. So the number of patients who were treated in the Cilta-cel arm as a study treatment were 176. In the standard of care arm, 208 patients received standard of care therapy. Majority, almost 85% of patients received DPD as standard of care, while the remaining patients received PVD. When you're looking at the two groups were well balanced in terms of baseline characteristics, including in high risk profile. For example, patients with the soft tissue plasmacytomas, with the high risk cytogenetics, with triple class refractory status. There are 22% of patients overall who are refractory to daratumumab. So what did the study show? The study showed that it met its primary endpoint. That means the Cilta-cel significantly reduced the risk of disease progression or death by 74% when compared to standard of care. The hazard ratio in this study was 0.26, which is very impressive and perhaps the best hazard ratio that has ever been reported in this patient population in randomized setting. The median PFS was not reached, and it was 11.8 months in the standard of care arm. The 12-month PFS rate was 76% in the Cilta-cel arm and 49% in the standard of care arm. At the time, the median follow-up of these patients were about 16 months. Now, in addition, we also showed that the PFS benefit was seen in all patients, all subgroups of patients, including the patients with high-risk subgroups, which are the difficult-to-treat patient population. We also showed that Cilta-cel led to improved or higher response rates versus standard of care. Patients in the Cilta-cel arm had higher overall response rates, complete response, and better, and the MRD negativity rates compared to standard of care. Now, when you look at the patients who received Cilta-cel as a study treatment, 176 patients, 99% responded, 86% achieved complete response or better, and 72% were MRD negative. And the 12-month PFS rate was 90%. When looking at the safety, the data from CARTITUDE-4 are consistent with the known profile of Cilta-cel. Specifically, when you look at the patients who received CAR-T as a study treatment and looking at the CAR-T-related adverse events, we found lower incidence and severity of adverse event like CRS, ICANS, movement and neurocognitive events, and other adverse events like cytopenia in much lower rates and severity than what we saw or what we observed in CARTITUDE-1 patient populations who are kind of more than 3 prior lines. So in summary, what to take from this CARTITUDE-4 data? We saw in this study, when you compare with the standard of care, which are 2 highly effective standard of care regimens, Cilta-cel leads to superior efficacy responses with manageable safety profile. The PFS benefit can be seen in all subgroups, including the high-risk subgroups, which are difficult to treat patient population. Cilta-cel leads to deep response and durable responses compared to standard of care. And if you use Cilta-cel in early lines, that could lead to improved tolerability by the patients. So all this data suggests that Cilta-cel could be a new standard of care for patients who are lenalidomide refractory as early as after the first relapse.